Nursing and midwifery ectopic pregnancy. Ectopic pregnancy. Definition. An ectopic pregnancy is where the fertilized ovum is implanted in any tissue other than the uterine cavity. The fetus produces enzymes that allow it to implant in various types of tissues. Epidemiology. Ectopic pregnancies occur in about 1 out of every 50 pregnancies, 20 out of 1,000. In developing countries, EPK's fatality rates is 1-3%, 10 times higher than that reported in industrialized countries. It is the most common cause of death among women during the first trimester at approximately 10% of the total. Pathophysiology. The trophoblast develops from a fertilized ovum and invades deeply in tubal wall. Following implantation, the trophoblast produces HCG that maintains the corpus luteum. Corpus luteum produces estrogen and progesterone to make environment favorable. The tube enlarges up to 8x and then becomes soft. Tubal pregnancy does not go beyond 8 minutes 10x2. Lack of decidual reaction in the tube. Thin wall of the tube. Inadequacy of tubal lumen. Bleeding of site of implantation as trophoblast invades. Nursing and midwifery ectopic pregnancy. Sites of ectopic pregnancy. Ampulla section -80%. Thimbrel end -50%. Isthmus -12%. Cornua interstitial part of the tube -20%. Note mortality of a tubal pregnancy at the isthmus and interstitial is higher as there is. Nursing and midwifery ectopic pregnancy. One outside the uterus and the other inside. This is called a heterotopic pregnancy. Often the intrauterine pregnancy is discovered later than the ectopic. EP is an obstetrical emergence. Managed/removed very early in the pregnancy, therefore ultrasound may not find the additional pregnancy inside the uterus. When HCG levels continue to rise after the removal of the ectopic pregnancy, there is the chance that a pregnancy inside the uterus is still viable. This is normally discovered through an ultrasound. Tubal surgery. Endometriosis, where endometrial tissue can be found in other places apart from the uterine cavity. Congenital narrowing of the tube. Tumors pressing on the tubes causing partial or complete blockage of the tubes. Congenitally long tube which is liable to kink. Smoking. Intrauterine device. Advancing age. Previous ectopic. Previous termination of pregnancy, Asherman syndrome. IVF and ovulation induction mainly leads to heterotopic pregnancy. Pelvic infections, e.g., pelvic inflammatory disease, may lead to salpingitis, destruction of the cilia. Formation of adhesions. Nursing and midwifery ectopic pregnancy. Signs of tubal rupture. On history taking. History of amenorrhea 6-10 weeks. Patient complains of a feeling of fainting, dizziness, those vomiting, but this depends on degree of bleeding. Patient complains of colic acute abdominal pain which is localized in the iliac fossa. I referred to the shoulder especially on lying down due to blood irritating the diaphragm. On examination. Signs of shock, e.g., cold clammy skin, rapid dirty pulse, low blood pressure and low temperature. Patient is anxious and restless. Pallor of mucous membranes. On palpation. Abdominal tenderness especially on the affected side. Abdominal muscles become rigid due to mother guarding against pain. Abdominal distension due to presence of blood in the abdominal cavity. On vaginal examination. Tenderness on movement of the cervix and a mass is felt in the lateral fornix. Painful mass in the pouch of Douglas. Nursing and midwifery ectopic pregnancy. Laparoscopy or laparotomy reserved for women with acute abdomen and hypovolemic shock. A laparoscopy in very early ectopic pregnancy rarely shows a normal-looking fallopian tube. Coldocentesis, in which fluid is retrieved from the space separating the recto-uterine pouch of Douglas, is a less commonly performed test that may be used to look for internal bleeding / any fluid from ruptured ectopic. Hulen bleeding in subcutaneous fatty tissue around the umbilicus which is indicative of intra-abdominal bleeding. Lower abdominal pain, unusual vaginal bleeding, and positive pregnancy test.